a nice session here today. I'm Dr. Daniel Donahoe. I'm the moderator for this session of implementing Global Surgical Collective. It's my distinct pleasure to be here today. We may have a couple of folks who are joining a little bit late, but we're going to go ahead and get started. So I'll start by sharing a quick few set of slides where we'll introduce the topic and our esteemed panelists. So first, a brief word about one of the organizing forces around this, which is the Surgical Data Science Collective. This is a 501c3 nonprofit that has been around for the last couple of years to create really a global community around surgical data. We operate and deploy a platform for viewing, sharing, and understanding surgery itself through surgical video and other associated data. This involves the work of many, many surgeons from all around the world. We're now actually at more than 200 and thousands of hours of surgical video from several different surgical domains are represented here, as well as research partnerships with large academic institutions, both inside the United States and most importantly, outside the United States. And it's to those partnerships that we really want to turn now. For those of us who practice, and I'm a practicing surgeon, as are several of the others on this panel, we know that we have a massive problem in surgical equity or inequity, where most people on Earth do not have access to safe surgery, and this access is compounded by difficulty in accessing high-quality surgery, such that 4 million people every year die within 30 days of surgery, according to a paper in The Lancet, which is more than die from lung cancer and diabetes combined, and makes surgery potentially one of the leading causes of mortality worldwide. Unmeasured in this number, of course, are the patients, the people really who don't have access to surgery and can't even receive these kinds of services. There are some key drivers of this phenomenon. There are too few surgeons, and that is inherent in the training process and how we think about surgery. But more importantly, there's a tremendous disconnection, even within the high-income setting, but particularly comparing between and across different jurisdictions and countries. There is a significant siloing of expertise within institutions and then within surgical domains. And we largely believe that the promise of artificial intelligence in medicine, outside of some areas where you can deploy chatbots, has largely been unfulfilled. When we look at the current model of surgical training, it shouldn't be surprising to see these end effects. This model was very effective at achieving its stated goals, but I think our global goals now in 2024 are a little bit different than what they were in 1920. The current model of surgery relies on one-on-one training that's essentially local and requires many years to achieve a fairly broad general expertise prior to a more intensive specialization or subspecialization in individual practice. We typically view surgical training as a unidirectional process of knowledge transmitted from a more knowledgeable other to a learner. And this is a one-shot endeavor because surgical training can take 5 or 7 or more years. Few want to repeat it voluntarily. As a result, we see the current effects that we've described. We strongly believe that we need better training for surgeons, and we believe that technology here can be helpful. We believe that better training is possible, and that's shown by some, across many domains, this widely replicated effect that our top surgeons, in terms of outcomes, can have many-fold better outcomes than the lower quartile or the bottom surgeons. This is a particularly important area of work because each surgeon will treat 10,000 patients or more in their career. And we believe the proactive approach using collective action, implement technology, and improve surgical research training worldwide can help us address this critical need. At SDSC, what we do is we connect surgeons and hospitals who have tremendous data and great both local and global context for the problems that need solving. but may have gaps in their ability to implement technical advances with researchers and a structure that allows this collaboration to happen. On the other side of the coin, researchers often don't have access to data, don't have a place to deploy their innovations, but do have tremendous technical talent and computational resources. So by putting these two things together through a living data platform that's in use worldwide every day, we believe that we can achieve more global and equitable access to surgical knowledge, change training from a one-way to a two-way feedback system, and accelerate academic research with very practical implementations focused on how to improve the technical craft of surgery. I'm very excited to introduce our panelists. In addition to me, I have the honor of sharing this panel with Margot Masson-Forsyth, who's the Director of Machine Learning at SDSC and a leader in artificial intelligence and computer vision, with Doris Spitzer, who has extensive product experience both in the public and private sector in implementing innovations to achieve technical and domain-specific impact. We'll also be joined by our colleagues who are in clinical practice, including Dr. Hamisi Shabani, who's the head pediatric neurosurgeon and consultant in the Mobili Orthopedic Institute, as well as Dr. Barnabas Alayande, a general surgeon at UGAG in Rwanda, and Dr. Timothy Singer, a resident neurosurgeon at George Washington University, who has significant global health interests and expertise. So I want to thank everyone for being here for this wonderful panel discussion, and I'm very excited for some of the questions that we'll be able to answer. I want to invite the members of the audience to use the chat that's present here, which we will try to moderate to ask questions, and we'll do our best to answer them, as well as this session is being recorded so that others can benefit from this who weren't able to be here today. So thanks everyone for being here, and I look forward to starting a little bit of our panel discussion here. So for the beginning of the panel discussion, I want to start with a couple of brief questions for targeted members of the panel, and then we can move into a more general discussion. So for Dr. Alayande, this entire meeting is considering navigating new frontiers. And you're a global health leader as well as a surgeon. And I'm wondering if you could share a little bit about your perspective on how these partnerships can be constructively created to create more of a global surgical collective.
Thank you so much, Dan. Thank you for having me here. I just think that as we go forward in the ethos of global health, we've come to a point where global must be global, and we have to start thinking about how everyone can collectively come together to advance this concept of global surgical care. And so for example, I'll just pull from the example of the University of Global Health Equity where I sit. We know that there are issues around global surgical care. We know that there are challenges, but how do we address them with partnership? Paul Farmer was talking about few things in life that can be achieved outside the concept of partnership. But when we're doing these kind of partnerships, we have to be very deliberate about them, deliberate about the fact that there are no givers or receivers, deliberate about the fact that there is equity, and as you highlighted in the slides before, that everybody has their currency by which there is some kind of exchange going on, and at the end, global surgery is or surgical care, global health is better. For instance, I know that we've started exploring some ways to move forward with this kind of partnerships between the University of Global Health Equity and the Surgical Data Science Collective, thinking about the shared mission of improving surgical education outcomes and surgical health outcomes through and innovative data-driven approaches. So this kind of partnership has to be aligned with what all the parties are thinking about. For instance, at UGHU, we're thinking advancing surgical care, education. We're developing a residency program, expanding laparoscopy and surgical training in Rwanda as we do that, etc. And so this partnership will leverage on the strengths from all parties, leverage SDSC's surgical video repository and educational platform to kind of improve the training for medical students, residents, practicing surgeons. And we're also thinking of how to scale this kind of scalable education platform tailored to local needs. And we're already thinking through what should be there, what is primary, like looking at the 10 top laparoscopic surgical procedures performed in Rwanda. So I think that there is need to see what the needs are in local context, really, and then respond to those needs in a way that is equitable. So education, video platform development, simulation training, research opportunities, all these things are part of how we can create this network or this collab, this collective in such a way that there is win-win on all sides. Over.
Yeah, I think that's really well said. And I wonder, you know, from your perspective, I know that the adoption is often easier said than done. And that's true in whatever context and whatever system that we may be in. And we should be really thoughtful about, you know, how we decide to adopt some of those technologies. So I'm curious, for you specifically in laparoscopy, if you could share some of the things that you're hoping to see or achieve in terms of health outcomes that might potentially be improved if this were able to be promulgated more widely as we hope.
I think in the final analysis, it is the health outcomes that matters, and then the costs of care, for instance, and if we are able to promulgate this and push, there's some laparoscopic surgery going on in Rwanda at two of the district facilities, Kibagabaga and Kibogora District Hospital. There's work at the tertiary facilities. It's not as advanced, and then at a few private places. But making this available to all is going to be reducing the time spent in surgery, reducing costs for patients from the perspective of time lost from work. When you could have a cholecystectomy and go home in the evening, why should you still be in hospital for a week, you know, with a huge scar? Even surgical site infections, we think that would also be handled. There are standards of care globally that we think we'll be able to bring into contexts like this and really expand by expanding training. We could also think of, again, I'm going back to the training aspect, because learning curves are there. There's a lot of training that has to be done for individuals to come to this point. But at the end, the patient does benefit from it. So just thinking about the final outcomes for these patients in terms of less time in hospital, reduced hospital costs, hospital bed space. We've got a lot of patients, backlog of patients that cannot come into hospital and have surgeries, particularly some elective, because there's not enough bed space in certain instances, right? And so if we're applying laparoscopic surgery, we're using the learnings from this kind of data science collective and using that for teaching and training, it will increase the throughput of our ORs and really eventually address the needs in the community. Over.
Yeah, and I think the last sort of most specific question for you, and you know other folks are invited to weigh in, is about the training capacity building. You know, this is something that in the US, for example, training capacity is highly regulated and actually is rate limited. There are a fixed number of spots and there's a very sort of defined context, and maybe we're not even so interested in expanding the number of it's actually quite controversial to expand the number of trained surgeons in the US, for example. Can you share a little bit about what you think the full capacity of training should look like or could look like, and you know potentially how having, more trainers or more throughput through the training system could look like for you?
I think we have to go back to what some people look through and curves plotted, modeling done, that there is at least the need for 20 per 100,000 of surgical providers, globally. The US, for instance, would have near or even above 40 per 100,000. But in many places, we don't have these. And the implication is that people are not getting the healthcare that they need, or people cannot. In fact, lives are being lost as I speak because in certain contexts, there is no surgeon, right? So I think it goes unspoken many times, but it's a reality that it, it is necessary to equip the next generation of Rwandan surgeons in LMICs with cutting edge tools and knowledge. We need to reduce variability in surgical performance. We need to reduce variability in surgical outcomes and then we need to expand training through innovative methods. I think that if we're able to get this right. It's tough. It's an uphill task. But if we're able to get this right and expand throughput, then we're really addressing the needs of the patients, and then we're expanding. It's a necessity, and we can draw from stories from individual patients, but we can also draw from stories of entire systems, right? For instance, in Rwanda, we have at some point done the Human Resources for Health program where people were coming from the US and twinning with Rwandan surgeons. And the current crop of leadership in the surgical space in Rwanda were birthed out of that kind of expansion of training. So the growing training that we have now within the country is as a result of people thinking outside the box and saying, what can we do differently? And I think that in this day and age of AI, this is a possibility. This is a space that can actually address the needs in a creative way. We did some research across the East Central Southern African region and just looking at training. And for some countries, looking at cardiac, for instance, surgery training, for some countries, it will take them 300 years to meet up at this current rate of training, 300 years to meet up with the number of providers that can even barely minimally address the needs in the context. So I think populations are growing, Africa particularly. Pediatric populations are growing. We're now getting a more stable inverted pyramid. More elderly people are living. So there's more need. And I think that when we put all that together, if we don't expand training in surgical care or look for creative ways to do that, we're sitting on a tinderbox of go very, very wrong in the future. Over.
Yeah. Thank you so much for sharing that. I think that's a good question now for Margot in talking about training. You and I have actually been in surgical training courses together now, which I know was maybe a new experience for a computer scientist. Maybe not what you thought maybe some years ago when you were in your formal studies you would ever be doing. But could you share from your perspective on training what you've seen and learned around the surgical training process, and maybe help us remember some of the things that we've long forgotten about what it's like to start in this training process?
Sure. So yeah, no, you're 100% right. I did not ever imagine I would end up in a room being part of a dissection course for a couple of days. That was definitely not something I was expecting, but been a great couple of years of a lot of different learnings, and a lot of things have been surprising to me coming from outside of the surgical world, haven't done med school. I think the main thing that surprised me was the lack of standardization across different institutions and surgeons, and the way one specific procedure is done differently across the world. And I think that's where AI can help get started, at least by creating a standardized way of sharing all of these different procedures, or at least starting to talk together. And it can be done through AI as a tool, but I almost see it as a tool to get the social interaction started. Like all the surgeons need to talk to each other, and like Dr. Allende said, it has to be global. So like when we are building AI models using surgical videos, for example, we need to have surgical videos from all around the world and not only the US institution or only one US hospital, because it won't represent at all what is happening all across the world. And that was something that I was really surprised is already within the US, I've seen a lot of different methods on how surgeons do the same procedure, and that was quite surprising to me. And one of the thing that also I believe AI can be helpful is studying what are the best practices across all of these different library of videos that we're starting to collect. Can we actually link the outcomes with these videos and discover new best practices that can then be shared all across the world? And we don't even know where those best practices are going to come from. So I think that's where this huge library of surgical video is going to be really important and impactful, and no humans can actually go and watch all of these videos. So like we need AI to extract all of the features, because no one is going to sit and watch 4, 6 hours, 8 hours of videos. Even watching 10 minutes sometimes gets a bit lengthy. So that's why we need the AI. Um, and also for the learning curves that Dr. Allende mentioned, AI can be used as a tool to track these learning curves and give feedback to some of the training residents, and hopefully that could help have more surgeons all around the world.
Yeah, and for both of you, I think I think that there's sometimes a reaction, and I'd ask you to respond to this. There's sometimes a reaction, that would say, well, surgeons aren't going to want to have Big Brother watching their surgeries and telling them, oh, you only can do this, or you can only use this company's branded device here, right? That's a very dystopian view of how this could look. But I'm curious, you've both had interactions with various technologies and various ways of gathering knowledge and training. What has the reaction been like, or how do you see your first brushes with this kind of technology so far?
You want to go first, Dr. Allende?
Yeah, I think that yes, this is it's a natural and dated reaction, because over time people are coming to the place where you're realizing that this is the future of surgical care, especially for your own QI knowledge, for your own improvement of practice, for safety, for non-technical skills, particularly. All these things are coming together, and there is not going to be a way to effectively do this if there's not continuous monitoring. Yes, but I think that over time there's a petering down of those thoughts, especially when people see it as the intention. What is the intention of this? Is it to get you to sued or get you to court to say you did a bad job, or is it rather to improve you and make you better than what you were, or how you practiced with each patient? So I think that as we clarify intentions, this comes forward. But I'm sure that our conversation will still lean towards the ethical and then the data considerations here, because we know that things are changing, and getting ourselves to the point where this kind of data is collected is another hurdle. But I'll leave Margot to just tell us her thoughts around that. Over.
Yeah, I think, well, that was the first time I talked to you, then that was actually my first question. I was wondering why a surgeon would want this kind of feedback. And then throughout the years, talking with a lot of surgeons at different levels in their career, I've seen a really big want. People actually want this kind of feedback, and they want to know how to do better. And I mean, a lot of the time, these are people who are extremely passionate, and they want to do a good job. And that's more of what I've seen from my personal interaction in this world. I, of course, don't have the whole picture, but I think that there is definitely a good part of surgeons who want to have this kind of feedback and want to get better. And a lot of the younger residents, they really are much more techy than previous generation, and they really want to go on an app and kind of track how well they're doing. It's almost gamifying the learning curve. But I've seen a lot of really big enthusiasm, and people want to be part of it. People want to help us develop models. So I think all of it is built on trust. And that's why SDSC is here, because like you said, it has to be done carefully. It has to be done with the clinician. It has to be done by the right entity. And that's why SDSC was created, so that we can ensure that this is done properly with the right people in the room.
Awesome. I want to open it up if there are any questions from the audience. Feel free to put them into the chat, and to welcome Dr. Shabani, who we previously introduced as a professor in pediatric neurosurgeon at Moy and Mobility Orthopedic Institute. So very, very grateful that you could make it to be with us today. And we're going to segue into the second portion of our panel. So I'll let Dr. Singer take it away from here, and we'll circle back with all of the panelists for some summarizing thoughts at the end of the segment. But thank you guys so much. And Dr. Singer, go ahead.
So I'm Timothy Singer. I'm one of the neurosurgery residents at George Washington University, and I work closely with Dr. Donahoe, both clinically, and then have gotten to be one of the that role. I've had the pleasure of meeting Dr. Shabani, who I'll let him introduce himself momentarily here. But overall, we are building a surgical partnership around education that's meant to leverage the SDSC platform to support the residents at Muth and Billy Orthopedic Institute. I've got a couple of questions for Dr. Shabani that we'll go through in the next 15 minutes. And then Dor Spitzer is the third in our trio, who's been facilitating our collaboration and helping us on the technical side. So Dr. Shabani, the floor is yours if you want to introduce yourself, please.
Yeah, good morning, good afternoon, good evening, everybody. And thank you for inviting me to this auditorium. My name is Hamisi Shabani. I'm the senior consultant neurosurgeon at the Mobility Orthopedic Institute. I'm also the head of the pediatric neurosurgery department under the Directorate of Neurosurgery. Our directorate has three departments: the general neurosurgery, the pediatric neurosurgery, and the conglomerate of the rest of the neurosurgical subspecialties. We call it endoscopic, functional, and the endovascular neurosurgery, clumped together. The department, the director here in Tanzania has a total of 14 specialists attending neurosurgeons. I am the senior consultant, and I'm leading the other two consultants, and then the rest are attending neurosurgeons. We have a residency program, and we have a number of students. I'm also the adjunct lecturer at the local university here at Muhimbili.
So my first question is, can you describe the different ways that one can become a neurosurgeon in Tanzania? And this plays off what Dr. Aliande was saying, in that there's different skill sets that people bring to the institution when they arrive, and part of creating parity across different surgical levels. So what are the ways that you can become a neurosurgeon in Tanzania? And I'm sure it applies to East Africa in part as well.
Yeah, just to mention, there are three pathways. And before that, I will tell you, I am the youngest in the department. The department had been composed of two neurosurgeons for over 30 years, since 1990. And I just joined the department as a specialist in 2005. So if I tell you the development which we have done since that, this is where I come to bring you now the 3 types of courses, because before that, there was no course, there was no training program in Tanzania. There was the traditional course which has been actually registered with the local university is the Master of Neurosurgery, Master of Science of Neurosurgery, which actually enrolls the general surgeons, somebody who has qualified as a surgeon, to just now join the neurosurgery course for 3 years, which actually is not enough for someone to become a competent neurosurgeon. And 2 years will be local training, and a 1 year a fellowship outside the country. And most of those who opted for that option, for that treatment, for that training option, were getting scholarship to Switzerland, Germany, and also in South Africa. The other course, the other program, which is, is people to be trained abroad. I was trained in Japan, and I took my residency, which was a clinical PhD in Japan, in Nagasaki University for 5 years. And I came back to do my internship, and I completed 6 years course of residency in Tanzania. So this is how I did. We have a big number of people who are now running the department who were trained in that way. There are 2 neurosurgeons from Japan. There are 2 other neurosurgeons from South Africa who were trained fully in South Africa, registered with the medical board in South Africa. And then we have 1 neurosurgeon who was trained in Algeria. Morocco, sorry, Morocco, with a registered board in Morocco. So these are the few neurosurgeons who now started to formalize the Master of Science course, which is now extended into 4 years of training program. So it now improved from 3-year training program to now 4-year training program with no fellowship abroad.
And so,
then,
yeah, please.
Yes, and then yes, yeah, please, you can ask, because I was going for the 3rd one. So the 3rd one is the one which is shared within the sub-Saharan colleges. We call it College of Surgeons of East, Central, and Southern Africa, COSECSA. This college is registered in Ethiopia all the way down to Namibia, except South Africa. So all these countries you find there in between, the sub-Saharan, from Ethiopia in the north to Namibia in the south, almost 17 countries. They were trained by COSECSA. COSECSA is like other residence programs in UK, the FRCS, or the board registered in US. Someone is trained locally in the hospital, and then gets the didactic lectures, journal clubs, everything online, sponsored by the Royal College of Surgeons of England. The Royal of Ireland, RCSI, and it's fully funded by RSSI. So these are the 3 ways somebody can train as a neurosurgeon in this region, and especially in Tanzania.
So we've begun to build our collaboration around a surgery called endoscopic third ventriculostomy, which is a surgery for hydrocephalus. And in building that, we've talked a lot about, in our collaboration, the variability amongst the different trainees that you work with. And so as you describe these 3 different training paths, how are you hoping that in our collaboration, you can build parity and kind of equitable skills through the collaboration that we have for the different levels of trainees that you work with?
Yeah, it will be very useful because it will actually I don't know whether this is the proper word between supplement and complement. I will tell you this part of the world to have resources for knowledge is very scarce. That's number one. So creating a platform where someone can get these resources for training, that is very wonderful indeed. That's number one. For the trainees who now from different areas coming back, I will tell you the experience we got. Those who were trained in South Africa, they know how to do the rigid scope. I was trained in Japan. Of course, I got a chance to do the rigid scope, and then I joined the Professor Benjamin Wharf fellowship, and I mastered a flexible endoscope, which is actually the instrument which is readily available in this part of the region, and you can see the difference in the skills and the practice. So actually, there's a need for uniformity, and bringing up this platform, which I hope to be online, and with time it can be modified into a 3D and all this technologies. It's a good thing indeed.
And so as we get going, a question for both you and Dor from a technical side. What are some of the challenges that you anticipate, and how as we go through some of these challenges, do you think that we'll have to work through them? Dor, I'm curious your thoughts as well.
Yeah, as we move along in collecting this data, I think no, like any other research, these are challenges which we can overcome. I mean, we have to pass through the bureaucracies of applying and getting vetted to pass through. But that's not a big deal because everyone who does research knows that. In terms of any other challenges, I don't think so, because this is a new opportunity for people to learn, and it is really anticipated, and it will be very well received in this part of the world.
Thank you. Dor,
Yeah.
what are some of your thoughts?
So thank you, Dr. Shabani. I tend to agree that challenges that we face, we will overcome them. And that's the external challenges. But I think the biggest challenge that we have that poses the biggest opportunity for us is the internal one. The one that where we boast the relationship and create a two-sided value for both MOI and SDSC, and that's the initial goal for our collaboration here. What does our customer want? How do we get the best? How do we utilize SVP, which is SDSC's platform, in the best way in order to get to that place? And I think to overcome this comes with a lot of effort, and it's effort from both sides. And I'm happy that we're starting to seeing the effort being put into this. And I'm very hopeful to the opportunities of value that we can create working together.
Yeah, it's true. Thank you. If we start with the images, we can study the anatomical variations, and then see the the techniques, there's this very little things like going on the left, going on the right, once the scope is inside. And how to perforate a Liliequist membrane. This Liliequist membrane of a very young patient and this very old patient, uninfected cerebrospinal fluid. All this will be in, if all this is in one platform, the learning curve, the learning curve will be short, instead of going through the logbook, my logbook and somebody's logbook, but now I can see everyone's logbook in just one platform, and this is a good thing indeed.
It's going to be exciting as we build up more of the library of surgical video between the different sites here. And it actually gives me a good chance to hand off here to Dora and Margot and talk a little bit about how you see these global collaborations growing through the SDSC platform over time.
Thanks, Tim. I'll start by explaining a bit what SVP is, because I think that's the pinnacle of what SDSC is doing. So I come from an innovation background, business, and I think one of the most interesting theoretical approaches is about the innovation arena, where we are seeing innovation happening from a sustained relationship between academic, technical, business, and user sides. And I think what SDSC is trying to bring to light is a way where all of these pinnacles join hands together and work toward a shared goal, which is improving surgical outcome. SVP, which is the platform that we offer currently for everyone, is a place where you can store your data, collaborate on that data, so you don't have to go into your logbook and share that logbook around, but also where you can access models that we create with academic researchers all around. And that's where the magic happens with this collaboration. And again, I'm very hopeful for the foreseeable future to happen. Handing in to Margot for the technical discussion.
Thank you, Dor. So like I mentioned earlier, my background is in AI and mostly computer vision. So surgical videos was a pretty good fit when I learned about the thousands of surgical videos that were not being used. And I think that the surgical video library and other data now that we are gathering is going to be really important. And it's going to change a lot of things in terms of education, like we've mentioned several times during this panel. But more technical details of what we can do at the moment, we've been working on developing several AI models that are able to extract information from surgical videos. So for example, a pretty straightforward one is surgical tools detection that we can use to extract tools kinematics. So then we can study how the different tools are being used, and that is something, for example, that can be used to track learning curve. How many times did the tools were crossing, or how many times was this specific tool used in a specific phase? Those are kind of questions that we will start exploring once we have all of this different collaboration working. So here's something important to mention is we're able to develop these AI models that work on surgical videos, and then once we're done with that, we have all of the clinical experts coming with the hypothesis and the question that they want to study, because it's not with the computer science background that we will know what questions we should be looking at, but we're able to get all this information from the videos and start answering questions that we couldn't answer before. And that was mostly because, one, we didn't have the surgical videos all in one place, and two, we didn't have any AI models that were able to actually perform on a diverse set of surgical videos. And here, important word is diverse. It is extremely important to have AI models that can work across different surgical videos from different sites and different procedure types. So that is something that we're spending a lot of effort on. And last thing I will say here is our goal is not to develop any cool AI, is how I call it. I really want to focus on developing impactful and useful AI for the clinicians and the surgeons. And so that is what we're focusing on. So for a lot of the procedures, for example, endoscopic stomatostomy, we want to focus on what is impactful to detect on the videos and what do we want to focus on. It might not be the tools for this specific procedure, for example. So what else do we need to go and look for and gather across this diverse library? Handing back over to Dan, I guess.
Yeah, I know that we're running up against time here. So I wanted to thank, first of all, our esteemed panelists for being with us today from a variety of different virtual and physical locations. It's been a wonderful discussion. And I think that we're really the one message I would want to communicate to the broader group is that we're at the very beginning stages of this work, and we have phenomenal partners all around the world. And if this is something that is interesting to you, you can find us at www.surgicalvideo.io or email us at info@surgicalvideo.io. We certainly invite folks from anywhere on earth. There's no fee to participate in this work, to join this conversation. And there's substantial opportunities both for research projects, for leadership within the development of the organization, and for local implementation and solutions in domains that we may not have considered or for problems we may not yet be solving. If this is something that's interesting to anyone or they want to get involved, this is how you can do it. I want to thank Dr. Singer, Dr. Shabani, Margot, Dor, and Dr. Alayande for their generous time and participation today, and to thank the group for their attention. We look forward to meeting all of you soon and making some new friends, we hope. So thank you for your time, everyone.
Thank you.